he came to me one day with this invention that he had conceived. And when he started telling me what it was, he said, "Howard, I think I've got a better way to get feeding tubes placed for patients who need them." And my ears perked up a little bit. My mom actually had a feeding tube when I was in high school and college. My mom was a cancer patient, and a feeding tube was one of the therapies that extended her life and gave her a lot more time with our family. And I really appreciated it. And I also remembered it continuously having problems and getting clogged or infected or falling out. And I said, "Steve, if you've got a better way to do these, I'm all ears."
Shortly after that conversation, Howard and Stephen would fine-tune, and market their feeding tube placement technology and launch their revolutionary company, Coapt Tech. Their technology would give point-of-care physicians the capability to place feeding tubes, a procedure previously only performed by specialized surgeons. Coapt Tech would go on to receive over $10 million in funding, most recently closing $7 million in their Series B round led by Hunniwell Lake Ventures. They would also receive grants from the National Institute of Health and be among the top 50 healthcare companies selected into the MedTech Innovator Accelerator program. Before this company took flight, before all the grants and awards, before Howard and Stephen were even colleagues, there were two guys about to pursue careers in very different fields. To understand further how this company was made possible, we must turn back the clock to the early days of Dr. Tropello and Howard Carolan.
I grew up in northern New Jersey, not the kind of New Jersey people see on TV, but a little more rural and suburban. Definitely knew I was interested in engineering at a young age. I had that sort of medicine instinct too. Whenever someone got hurt, I always sort of gravitated towards them. People made it seem like medical school was so hard, and I was like just not looking in that direction. So I headed into engineering school to start, fell in love with computers, got distracted with the dot-com bubble. But as I was graduating, I had a job to work on Wall Street for JP Morgan to be a software developer for them. But the bubble burst, and I saw a lot of friends losing their jobs, and I thought maybe I could be one of those people too. I still had that medicine itch. And then I had an advisor who was nice enough to say, if you're confused about what to do in life, why don't you just stay in grad school? I'll pay for you to do research for me, and then I'll let you take pre-med classes. I was able to take the courses, take the MCAT, and after 2 years, I matriculated into medical school at UVA.
I grew up in a very eclectic area with very intellectual parents. They were both attorneys, and they encouraged me from a very young age not to become an attorney. So that was off the list. In college, I actually studied economics. Economics was something that I knew explained a lot of how the world works. Where things got really interesting for me and where the rubber hit the road for me was I had, through a set of personal experiences, a lot of interactions with the US medical system. My mother was an ovarian cancer patient, sort of late stage, and this was during my high school and college years, so a very formative period in my life. Through that experience, I was having a lot of run-ins with all different facets of medicine, and I got to learn a secret. And the secret is something that I think most people who haven't spent a lot of time intersecting with the medical system don't really understand. I think a lot of people think the US has the best medical system in the world. It is kind of a mess, particularly from the patient perspective. It is kind of a mess, and it is very challenging and frustrating. And I sort of reflected on a couple things. One, if my sort of sophisticated household had this much trouble dealing with the medical system, how the heck is the rest of the country and all of our citizens going to be able to manage that? And I said, if I can be in any way helpful to this operation, I'd like to try. And so I was able to apply my economics background to the healthcare system. And I was brought in at Johns Hopkins to help a group that had done a lot of things that were clinically innovative and resulted in a lot of really strong safety and quality successes. and they wanted to understand what is the bottom line impact of these things that have been good for medicine, good for patients. Are they good for the health system in terms of our financial health? And I started being actually asked and tasked to bring these groups of doctors, nurses, IT, pharmacy, and finance all together.
I found that what I was getting from this experience at Hopkins intellectually was these sort of two very opposing disciplines and sort of countervailing winds in some ways. It was really neat to try to bring them together, because one is clinical innovation, which is doing new things in medicine, right, and trying new stuff. And the other is patient safety, which is doing things we know work very consistently and religiously, right? And so one is experimenting and trying stuff, and the other is kind of hardwiring and really standardizing in protocol. And so I got this very broad education on how to do both of those things with some degree of effectiveness in these very complex environments, with a lot of different people with a lot of different responsibilities.
Now back to an understanding of engineering and medicine from Dr. Tropello, an understanding of economics and project management from Howard Carolan, and a combined fuel to make the world of healthcare more simplistic. The two were armed with the ingredients necessary to shake up the medical technology industry, and they would cross paths in none other than Baltimore, at Johns Hopkins.
I was working on, and at this point I was running a big project. I think it was probably a budget of $20 or $25 million. And this was an IT project to standardize care and to help the care team manage these very complicated patients in the ICU. Dr. Tropello sort of undersells it, but ICU medicine is really, really, really complicated. It's sort of like being in outer space, where one little failure can have catastrophic ramifications, right? And so you really need to do things right. And we'd learned a lot about what the right things to do were in medicine, but actually having those delivered consistently was not happening. And so we all collaborated to build this health system. That effort had a lot of successes. It had a lot of challenges, and it is sort of, Steve and I's common reference for a lot of what we learned in medicine. This was under Dr. Peter Pronovost, who is a luminary in medicine. And it was, like I said, a really, really great way to learn and to work with people who were creative and trying to move medicine forward. And that's where I met Dr. Tropello.
So I transitioned out of fellowship to being a full-time critical care attending, and I don't know, probably a half FTE as a research assistant at Johns Hopkins. And Howard was my boss on that project, and we worked together for, I think, a solid 3 years, Howard. As that project was going, I was still doing stuff over at Maryland. I had my own clinical stuff, my own research, and through frustrations in care, I just got fed up with not being able to do my own gastrostomy procedure for patients and having bad interactions with doctors who perform the procedure today. Where I really was forced to put pen to paper, I was working a shift, the doctor on call for a patient. She had accidentally pulled out her feeding tube at home, had a stroke, needed a feeding tube, and we tried to fix it, but I wasn't able to. And I called the GI doctor on call during the day, and I'm too busy, can't get it done today. Admit her to the hospital, and we'll get it done at some point. And that was just boiled my frustration over the boiling point. And there was no reason this patient needed to be admitted to the hospital. Not only did that put her at risk for increasing unnecessary harms in hospitals, but it's costly to taxpayers. And there was no reason that this procedure couldn't or shouldn't have been done the same day and the nice woman sent home. That was the patient that I guess is responsible for me later that night putting pen to paper and starting to figure out a way to do this.
Months after, Dr. Tropello's original frustration would morph into a tangible product that would one day become the PUMA system. Yet, before moving further, he would reach out to his old boss and soon to become co-founder.
He came to me one day with this invention that he had conceived, and it wasn't a infant. It was actually sort of a toddler. And I was surprised that it had developed, it had progressed a little bit. He had filed a patent. He had done some testing on it. So it wasn't just an idea. And I saw that he was serious about it. And when he started telling me what it was, he said, "Howard, I think I've got a better way to get feeding tubes placed for patients who need them." And my ears perked up a little bit. My mom actually had a feeding tube when I was in high school and college, and I had mentioned earlier some of the interactions with the healthcare system. My mom was a cancer patient, and a feeding tube was one of the therapies that extended her life and gave her a lot more time with our family, and I really appreciated it. And I also remembered it continuously having problems and getting clogged or infected or falling out. And I said, "Steve, if you've got a better way to do these, I'm all ears." And what he shared stood out to me in a couple ways. One, it seemed simple enough that, I could understand it, but also that others would be able to understand it. It's one of these things that in retrospect, when we tell doctors about it, the first thing they do is say, "Why the heck didn't I think of that?" It's just got that sort of elegant, simplicity to it. And that's such a great thing to share and to see that reaction. But Steve was the clever guy who got it. And then, the other thing I realized is, and this is with my economics hat on, is the economics of this thing are just so true because we are empowering a new group of doctors to do this procedure. Lots of patients need feeding tubes. It applies to a lot of different conditions, strokes, cancer, diabetes. It's a big class of medical problems where feeding tubes are appropriate. And in today's world, those tubes can only be placed by these specialty surgeons, whether it's GI or whether it's IR or whether it's just sort of general surgery. But those docs aren't the docs who take care of the patients in the hospital. They're sort of the consultants who get called in to deal with these specific things. And rather than those doctors who already know the patient story and medical history, and they're already working with them and doing all these other things, rather than they having to call some other guy who's got a busy schedule and is very expensive to bring in and all this, these docs now on the front lines, they're empowered to put these feeding tubes in themselves. And that's never been possible before. That's never been something that doctors or patients had the benefit of. But that sort of cuts out the middleman, right? And that's another economic principle. If you can just do something without having to bring any additional cost into it, that's what's going to become the right answer. The technology that Dr. Tropello invented is important because it allows ultrasound, which has been on an exponential curve around the world recently. The costs have gone way down, so it's been a very accessible medical imaging modality for developing parts of the world and all different regions, but it's also used in the top ICUs in the developed nations. The issue with ultrasound is it has had a fundamental limitation of physics that was for the last 20 years unavoidable and impossible to get around, and that is simply that ultrasound doesn't work in hollow parts of the body. And the reason for that is ultrasound works sort of like a dolphin underwater. It sends a sound wave through a fluidic tissue, and those sound waves bounce back, and you can form a picture based on those reflections. When those sound waves hit a hollow part of the body, they scatter and they get lost and they can't come back to form an image. So it turns out that those hollow regions are some pretty vital parts of the human anatomy. It's the stomach, it's the lungs, it's the airway, it's parts of the pubic region. So Dr. Tropello's invention, you feed these catheters, which are just little thin tubes, into the body, and they have a balloon on one end, and inside the balloon there's a magnet, and that magnet attracts inside the body to an external magnet outside the body. And so when you have an external magnet pulling that internal magnet up the interface of the hollow cavity you're working in, and then you fill that balloon with fluid, What that does is it sort of simulates a fluid-filled vessel within a hollow region. What that enables is when you then look with ultrasound, you can see all the way into that hollow space. That fluid gives you a backboard sort of for ultrasound to go. You can now shine a flashlight into these places that were previously just darkened. The first thing that Dr. Tropello decided to do with this is to place feeding tubes. When we tell doctors about this, the first thing they say is, oh my gosh, why didn't I think of that? The second thing they say is, wait, oh, you can do this with the technology, you can do that with it. And they start riffing, and certainly the company has as well, on all of these other regions in the body and all of these other organs where you can now do things that you couldn't do before.
By enabling ultrasound into hollow regions, this technology certainly could have more applications than placing feeding tubes. So we asked them, what is to come with the future of Coapt Tech, and where would they focus their attention on next?
We invested in Coapt Tech because we believe its PUMA system has the potential to transform gastrostomy and other related surgical procedures, enabling them now to be performed by skilled medical professionals in critical care, bedside care, ambulatory centers, skilled nursing facilities, and long-term acute care hospitals, instead of the surgical suite, thus making these procedures more readily accessible.
The next stop I would like to take is placing tracheostomies with our coaptive ultrasound PUMA technology, but there are others as well. Controlling the vasculature, right? Vascular access, controlling the airway access, controlling nutrition, right? When someone is truly critically ill, we usually transition those folks to having not only a gastrostomy, a permanent feeding tube, but a tracheostomy. And if Coapt Tech can own that market, Coapt Tech essentially controls the flow of critically ill patients throughout the world.
I would add that we are in a really exciting time as a company because we have hospitals where this has become the default method, the gold standard for how these procedures get done in the hospital. From there, once we have established this method as legitimate in medicine broadly, we will be able to jump to some of these lateral expansions of the technology that we think are going to multiply the values of the accounts that we get. The last thing I would say about the world right now and our product is COVID has introduced a ton of uncertainty, obviously, in how care is taking place, and it's shaken up in a lot of ways traditional medicine, where those consultant specialists have less of a role, or a different role perhaps, and the frontline teams like those in the emergency room and in the ICU, they've borne incredible responsibility for managing this pandemic and the patients associated with it. They're growing in importance, in power, in ownership of patients in medicine. And so we think they're going to emerge from this pandemic with an even greater appreciation for the ability to do things on the front lines, manage patients at the point of care, rather than needing to rely on other specialties. With our device, the team can place a feeding tube right where the patient is at the point of care without having to send them to a surgical suite or bring in other people who aren't already in the picture. And so what that means is a lot less cross-contamination.
With the ability to save patients and hospitals time and money, the ability to lessen cross-contamination in hospitals during this COVID-struck era, and two founders like Howard Carolan and Dr. Steve Tropello, the sky is the limit for this upcoming company. To find out more, you can visit their website at www.coaptech.com. Thank you for listening, and be sure to subscribe to Hunniwell Lake Ventures for more stories like this.